All right, good morning, everyone. Thank you for coming to the Center for Clinical Trials and Evidence Synthesis seminar series. And today I'm very delighted to introduce Dr. Chris Schmid, who is a professor of biostatistics and co-founder of the Center for Evidence Synthesis in Health at Brown University School of Public Health. Dr. Schmid's research focuses on methods and applications for meta-analysis, particularly Bayesian methods and software, and on predictive models derived from combining data from different sources. He has published extensively on meta-regression and multivariate methods, including network meta-analysis and combining N-of-1 studies. Dr. Schmid is a fellow of the American Statistical Association and has served as chair, program chair, and counsel of the section's representative for the section on health policy statistics. And he's the founding editor of the Journal of Research Synthesis Methods and member of the Institute of Medicine Committee that established national standards for systematic reviews. He currently directs an ARC-funded training program in evidence synthesis, focusing on comparative effectiveness research and patient-centered outcomes research directed at mid-career professionals and users of healthcare evidence. And today we're very lucky to have Dr. Schmid here, and he will be talking about N-of-1 trials. Thank you.
Thanks, Tianjing. So I'm really happy to be here. I am going to talk today about N-of-1 trials. How many people know what an N-of-1 trial is? Okay, so, and how many people have actually done one? Okay. Oh, okay. So we've got some experience here. N-of-1 trials, I'm going to try to explain to you what they are and tell you a little bit about some of my experience with them, both practically and also in terms of how you would set them up and how you'd analyze them. And if anyone's got any questions at any point, just ask. I'm happy to stop and explain. So I'm going to start off by talking about sort of what's the motivation for N-of-1 trials. Why do we do that? Why might we do them? What are some of the unique features of them that differentiate them from other studies? A little bit about how you would analyze them, although I'm not going to get into a lot of details on the models. Talk about some examples that I've been working on, show you a little bit about how we might present results to patients, and then at the end I'll say a little bit about how we might combine them into a meta-analytic framework. All right, so the motivating idea behind the N-of-1 trial is that when you have a clinical trial, you're usually just estimating the average treatment effect. And so we know that not every individual is going to respond that way, but we usually don't have enough power or enough diversity in our sample to be able to get at all of the heterogeneity that might arise. So, if you look at this Gaussian curve here, you can see that there's an average treatment benefit at 0.5. And so that's the middle of the distribution. You'd say on average people are responding positively here. Now, there might be some small area around 0 of no benefit where you think that even if there's a small benefit or a slight harm, it doesn't really matter because it's sort of a clinically insignificant region. So think of the gray region there as that. And so anything to the right of the gray region would be considered a benefit. Anything to the left of it would be considered a harm. And so you can see that even if our overall benefit is positive, there are going to be some people who are not going to benefit. In fact, they might even be harmed. And so that's the idea of heterogeneity. And so if we're focusing on individuals, we want to figure out who those people are so that we can differentiate who should get the treatment and who shouldn't get the treatment. And so this is very patient-centered in the sense that patients want to know what's best for me. So in general, when we look at clinical research, a lot of doctors, when they're practicing, are using the evidence in the literature, but they're also using their own personal intuition, their own personal experience. And so if they have used a certain treatment effectively, they're more likely to use it in the future. And particularly, they're interested in treating individuals. So the fact that some treatment may work well on average is informative for them, but it may actually not be the most important piece of information they're trying to bring into practice. And we know that research knowledge is generally produced centrally. You have clinical trials that are run by companies or by universities or other groups. And the relevance to local practice may not be readily apparent. So we all know the difference between efficacy and effectiveness. Some studies will show that a treatment is effective or is efficacious, but that's often in a very ideal setting. And so clinical trials are addressing specialized populations, specialized conditions. We oftentimes target them at individuals that we think will respond well. This is particularly true if it's done commercially because you're trying to get a product approved. And so the community setting is very underrepresented. We don't necessarily know how it's going to work in regular practice. So the idea, another motivating factor for an N of 1 trial is that the N of 1 trial is being conducted on an individual. So you can direct this not just to try to find out where the individual is getting benefit in terms of heterogeneity, but also where the individual is getting benefit in terms of their location. Can you actually show this thing is beneficial in a particular setting and environment? And so we know that there's a lot of missed opportunities in the research endeavor because we're not running these trials at a local setting. We're running them in these idealized settings, which are say like academic medical centers. So we want to expand the research enterprise, and so this is another motivating factor here. And so that sort of raises the issue of whether if we experiment on individuals, is this clinical practice or is this human subjects research? So I'm not going to get into that idea, but it is an important one from the point of view of N of 1 trials. For example, do you need IRB approval to do these studies? And some people would argue that yes, you do, and other people argue that you don't. And we've written a report for AHRQ a couple of years ago and devoted a whole chapter to this topic and basically said that, if you're doing this for research, if you want to generalize this, then you really do need approval. If it's just an intervention that's done for your patient and you're not going to publish this, you're not going to try to generalize it, then you don't. So another motivating factor here is this whole area of personalized medicine, which of course is taking off these days with all the introductions in genomics and genetics. Predictive models are becoming very, very big and very useful. We have electronic health records, which are going to give us masses of data, which hopefully will allow us to dig down to the individual level. We have this idea of small data, meaning data that are collected on a micro level. For example, genetic data to some extent are small and to some extent are big, right? There's masses of it, but it's being directed at the individual. We have the mobile apps, which are becoming very common these days, and I'll show you in one of the examples we've used here. We've used a mobile app to collect the information. And then there's all kinds of organizations like 23andMe and Healthy Heart and so forth, which are collecting data on masses of people, are using social networks to reach out to people and to gather information and then try to spread the findings that they have back to individuals. So what is an N of 1 trial? An N of 1 trial can be defined to be a trial in a single person. It's a multiple period crossover trial. So a crossover trial means that if you have two treatments, each individual gets each treatment, either in an A-B fashion or a B-A fashion. You would randomize the order. So the only difference in an N of 1 trial is that you would get these treatments multiple times. So for example, if you had two treatments, A and B, and you crossed over 3 times, then you'd have AB, BA, AB, or some combination of that sequence. So the idea is that the more crossovers you do, the more information you have on the individual. There's actually, when you think of sample sizes here, there's actually 3 levels for these kinds of studies. One is the number of individuals, which is the usual thing we think about with sample size in a clinical trial. The other is the number of crossovers that you do. And the third is the number of measurements you take within each crossover period. For example, you might put somebody on a treatment for 2 weeks and then cross them over to another treatment for another 2 weeks. And you might take daily measurements. So you're getting 14 measurements per period there. So statistically, what you have in the end is you have a long time series, right? But it's a time series where you're switching treatments back and forth. And so I'll talk a little bit more about that later. Now, the other advantage of this kind of protocol is that it's personalized. So you can have a different design for every person, right? So you could even have the individual design their own study in the sense of pick which treatments they want to compare and pick which outcomes they're interested in looking at. And so the clinician and patient can design their own study. So again, this is personalized medicine. It's also patient-centered because it allows the individual to have a say in what they're doing. And it also promotes decision-making because, of course, now you're doing this study directly on your own health. So this will help you to make a decision as to what you want to do in your own case. So, for example, you have low back pain. You go to your physician, and the physician says, well, we could try a couple of things. I'm not sure which one's going to work. You could set that up as a trial. And so it's in contrast to usual practice where, usually what happens is the doctor says, well, let's try this. And then if it doesn't work, we'll try something else. The idea here is that you would try both of these things multiple times. You try them in some sort of a randomized fashion, hopefully. And the idea is that there's variability. So, for example, your back pain feels better under one treatment, feels worse under another treatment. Does that mean the first treatment's working better? It might. It also might mean that your health, your underlying health is cycling. And so that particular week, you just happen to feel better on one treatment than on another. For example, you came down with the flu. So you were aching all over. That doesn't mean the treatment doesn't work. It just means that something else is going on. So if you can look at this over a longer time frame, then that allows you to get some idea about the variability. So one of the restrictions on N-of-1 trials is because you're doing this multiple crossover, and you need to actually return to the baseline at each period. So if I'm going to compare something across periods, they need to be comparable. And so I can't have a disease which is going to resolve. For example, somebody has an infection and I want to know which kind of antibiotic to treat. Once the antibiotic has resolved, I can't run that study any longer. So you need to have uncertainty about the treatment, which is always the case with clinical trials, but it needs to be a stable chronic condition, or at least something which can return to the underlying baseline effect. The treatment effect should be heterogeneous because otherwise, if everybody has the same response to the treatment, we don't need to look at individuals. We can just look at an average. They need to be short-acting because we're going to be doing these multiple crossovers, and if it's not short-acting, the trial's going to last forever. And they have to have a rapid ramp-up in the sense that they have to take effect quickly. If you have a medication which takes a while to take effect, for example, a lot of antidepressants will take 5 or 6 weeks to have full effect, then it's going to take a long time to judge the efficacy of those treatments. You have to have a negligible persistence of the treatment effect, meaning that you don't want to have a treatment effect which lasts a long time, a drug that has a long half-life and stays in your system. So you don't want any carryover from one period to another. That's another way of saying you need to return to baseline quickly. You need to have outcomes that are measurable and easily collected because these are going to be done on an individual basis. You're not necessarily going to have a whole clinical trials network, fancy data collection scheme. The outcome, as I said, has to return to baseline after each period, and the patient and clinician have to be willing to put in the effort, right? So it's not going to work very well if you don't have somebody who's not willing to collaborate with you. But the idea here is that because this is being done for the individual, they may be more motivated to collect the data. So here's a schematic of what this would look like. This was a trial we did a few years ago comparing amitriptyline with a combination of amitriptyline and fluoxetine. A and C are the two treatment periods. We get in this trial, we have 6 periods, 3 Cs and 3 As. Each one gives you a measurement. You take the measurements on the amitriptyline, you compare them to the measurements on the actually should be combo rather than placebo there, and you get a multiple crossover design here, and you basically compare the two effects. Now you can think of, if you want, this is just sort of like a t-test, and that's one way you could analyze the data. There's more complicated ways of taking account of some of the complexities of the design here. But that's the basic idea. And so obviously there are going to be some assumptions there. Can you assume independence and so forth? So here's some examples of studies I've worked on in the N of 1 framework. As I said, the one I just talked about was a trial we did. It was funded by NIH for fibromyalgia. I'm currently involved in one where we're looking at kids who have ADHD, whether giving them melatonin will allow them to fall asleep more quickly, because these are kids who have trouble sleeping. I'm also involved in one where we're looking at patients with chronic pain. That's a mobile health application where the patients set up an N of 1 trial with their physician. They then enter the data on their smartphone. It's received to a server. We run some software in the background to do some analysis, and then we give them the results back. A recently funded trial for study with PCORI, which will be starting in January, I believe. We're looking at two different types of N of 1 trials. One is we're looking we're working with some patient provider networks, one on inflammatory bowel disease, looking at two different diets, a modified diet and a strict diet. And then the other one is in atrial fibrillation. We're looking at study what triggers people's atrial fibrillation. And so the use of the N of 1 is to figure out, for example, let's say you suspect that alcohol triggers it. You might experiment in having alcohol and not having alcohol as your two treatments, and see whether your disease triggers. So say a little bit about the design. Typically, if I go back to the picture here, you'll notice that these treatments are paired. So the first pair of design periods here, you have an A and then a C. The next period, you have a C and then an A, and then you have a C and an A. So we oftentimes pair them up here and randomize within those pairs, within those blocks. We can randomize or we can counterbalance. Counterbalance just means that we set the design in advance. Let's say, for example, you have a 4-period design. If you randomized within pairs, then you could either have A-B-B-A or A-B-A-B. If you had A-B-A-B, that would mean that A was always before B. And so if there's any kind of carryover effect or any kind of sequence or period effect, that might all get confounded. You might instead prefer to do A-B-B-A so that you avoid that. Most of the studies I've been involved with, we've done randomization, and that usually solves the problem, because particularly if you're doing this over multiple people, but certainly if you have a long enough study, the randomization ought to take care of any time effects, but you can also adjust for those in your analysis. We'd also hopefully like to blind them, although we can't always blind. For example, if you are looking at a comparison of taking a pill versus doing yoga, it's a little bit hard to blind that. You might be able to blind some of the analysts, but I don't think you'd be able to blind the patients. And as I said, one of the issues is the sample size. So replication is important. How many period crossovers do you need, and what are the length and number of those study periods? So this is not just a statistical consideration. This is also a practical consideration, because remember that people are doing this study. You want them to complete it. You don't want it to take so long that they don't get any benefit because they've got to wait a year to find the answer. You also have to balance how long the drug will take to take effect, and how long you want to follow people on it. And then how often you can take the measurements will often be a function of what those measurements are. So if it's a daily questionnaire, how did you sleep last night, you can take the measurements daily. If it's something that's a scale which is measured on a weekly basis, then obviously you'd only be able to take it once a week. If you can only take it once a week, you might want longer than a week-long period so that you get more than one measurement. And then finally, the big problem in a lot of crossover studies is this idea of carryover. So we oftentimes will design in a washout period, where we have a period of time where the person comes off the treatment in between the crossover, so that you can wash out all the effect of the previous treatment. One of the problems there is there's a little bit of an ethical concern, because now you're taking people off of treatment. So if they're really ill, or if they really need care, then that's problematic. So I've said a little bit about randomization and counterbalance. The idea really here is to control temporal effects, sequence effects, which are very common in crossover trials. So randomization may not achieve balance by chance. In a standard crossover trial, that's not really a problem because you're averaging across a lot of individuals. And so if there is a carryover effect and you have some people doing BA, you have other people doing AB, and so it should cancel out. In an N of 1 trial, that's more problematic because it's just one person. And so with blinding, of course, this is something we try to do. As I said, you can't always do it. What's sort of interesting here is that because this is a trial where you're interested in the individual's effect and their decision, some of the reasons for doing blinding may not apply. Sort of a silly example that came up in one of the papers we were working on was, what if you have, what if you are testing a blue pill versus a red pill, right? And there's no difference in the pills, but it turns out that the person really likes the color red, and so they feel better when they're taking the red pill. So normally you'd say, well, that's kind of silly, like that shouldn't have an effect. But for this particular individual, if they really do feel better with the red pill compared to the blue pill, then maybe that's what you should be prescribing them, right? So in that case, the blinding sort of means something different. It actually, you're trying to blind this thing, but they have a preference. So you're not going to be averaging these preferences out over a population. This is the preference for this individual. And again, that sort of emphasizes that the N of 1 trial has some specific, unique aspects that you have to consider that wouldn't be there when you're averaging across a population. You can obviously change the block size if you think that people are going to try to start guessing which treatment they're on if you're trying to blind. But that's not necessarily always the case. We do generally try to block because we want to make sure that if the person stops the trial, they decide, I've had enough, I think I know what's working, that you get enough information. Obviously, if you blocked in sizes of 4 and you had an AABB and they only did the first 2 periods, then you wouldn't have anything to compare. Okay, so in terms of replication, as I said, there's the number of crossovers and there's the number of measurements per crossover. So the number that you take, and this is always, of course, the question that statisticians get asked, is what's my sample size? And I'm actually kind of working on this with a couple of studies, and I'm trying to sort of reason this out. But it depends obviously on the different relationships of the variance components, whether the variability is bigger, across measurements or between individuals and so forth. And so that's oftentimes hard to gather. Variances are oftentimes guesses anyhow. And so now you're talking about several variances. And you have to also consider things like people dropping out and the idea that the longer you make the study, the more people may sort of fall off in terms of how much they're actually collecting the data. So if they're actually answering questions every day, people are generally very happy to do that for a while, but after a while they get sort of tired of it and they might forget to do it. And so your data will become less valuable as time goes on. So you may want to balance that out in terms of the sample sizes. Carryover and washout, I've mentioned. There's usually a bias toward the null if the carryover is present and not controlled for, but it's really hard to know if it exists. And the tests for it are not very powerful, so it's really hard to know kind of what's going on with this problem. And so you have to be very careful about what you do and how you analyze it. One thing we try to do sometimes with carryover is we try to design it away by a washout, but then, of course, as I said, there can be some ethical issues involved there. And it increases the study length is another problem. So again, it makes the study longer, which not only may reduce the individual's willingness to participate, but also means it's going to take longer for them to get an answer. And so you really have to be careful about this. One thing you can do is, for example, if you have a trial which has a week-long treatment period, and you think that there is a carryover, but you don't think it's going to last for more than a couple days because the drug will be out of the system, for example, you could just decide not to use the measurements from the first 2 days of each period. Use the last 5 measurements. Of course, that's an assumption. You'd have to be pretty sure about that. But that is one way around the problem, and you can do that because of the replication that you have. Okay, so basically, you're going to have another way you can do this, of course, is to do weighting. So that's a very strong weighting scheme where you give a 0 weight to the early measurements and a 1 weight to the later measurements. You could also do other kinds of weighting schemes. The problem, of course, is you usually have few crossovers, so you have to be very careful about doing this, that you're not throwing away too much information. There are other ways you can deal with it analytically, but of course, whenever you make an analytic adjustment, the validity of it depends on how good your assumptions are, right? So we have to be very careful about the assumptions we're making and very clear about what they are and what effect they would have on the results. And there are various ways that we could sort of generalize this to adaptive designs. Some of you may have heard of micro-randomization. That's really an N of 1 study in a sense. It just means that you randomize the person very, very frequently back and forth. And so in certain cases, you can do that. For example, if you're giving people reminders on their smartphone to do something, you can remind them and then not remind them and then remind them and not remind them and have them, entering things in a certain way. Or you could have a flexible number of crossovers. You can have adaptive designs where, for example, if one treatment seems to be working better than the other, you give it to somebody more often. You can incorporate information from other patients. I'll talk a little bit more about that at the end when I mention the meta-analysis. So, for example, if you're carrying out N of 1 trials in a bunch of people and most people seem to be responding, then that gives you some sense that the treatment works on average, and therefore you might go back and you might give it to the other people more frequently. Another design issue to keep track of here is that a lot of times in these studies we have more than one outcome. So again, these outcomes are designed the way the patients are thinking about things. And so patients are often interested in more than one thing. They might be interested in, well, how does this control my pain? But also, does it make me sleep any better? And does it make me less tired during the day, right? So now you've got this trade-off in which is the important outcome. Some people may favor one, some people may favor another. In fact, some people may choose completely different outcomes. And so one way that we typically deal with this in a clinical trial is we create composite outcomes, right? We put the outcomes together and we come up with some sort of average of their results. So the problem, of course, with composite outcomes is while they simplify the analysis because you've only got one outcome, they also have an implicit weighting to them. For example, a very common one in cardiology is major events where you combine the number of heart attacks and the number of strokes and the number of cases of heart failure or whatever, hospitalizations, and you put that all together into one outcome. But of course, that's assuming that all those events are equally important. And so that may or may not be what the individual is interested in. So you're balancing here this idea of standardization of outcomes versus customization. So, for example, if the patient is interested in how well they sleep, do you use a validated scale, in which case you've somewhat standardized it, but maybe the questions on that scale are not really the ones that patient is interested in, and so you might need to customize it a little bit. So again, there's a trade-off here. But if you're doing this in a community practice, you probably do not want to be getting into these questions because this is not where the expertise is on this kind of research. We typically don't worry too much about multiple testing here because we're actually making a decision on the individual level, so we're not sort of generalizing to a population. So, if we're not really thinking about random variation across a population, so we don't have to worry about, inflating our p-values and all that kind of thing. As I said, it's basically what your data are for a single N of 1 trial is it's a structured time series. So you're following people over time, you're taking measurements, and sometimes they're using one treatment, sometimes they're using another treatment. it's a little bit like some of you may be familiar with interrupted time series designs, where you have one treatment and then you interrupt that and you switch over to another treatment. So that would be like an N of 1 trial, but only with one crossover. Here you're crossing over multiple times. So how do you analyze those kinds of data? Well, a lot of times it's just done descriptively. You just have a plot. Here's where you were on A, here's where you were on B. Which one do you think you did better on? You could do some kind of a simple analysis like a paired t-test or a Wilcoxon test or something. That doesn't adjust for time trends because somebody's health may be changing over time. They might be getting better just in general. And so you need to adjust for the time trends. So now you're into some sort of a regression analysis. There's also this idea of carryover and correlation. These are measurements being taken repeatedly on the same person. They may be correlated. You feel better one day, you'll probably feel slightly the same way the next day. So how do you take account of that correlation? You don't have independent measurements any longer. And so these are some of the things we have to think about when we're doing the statistical analysis. So we've tended lately to be using Bayesian models here because there's a personalized decision here. So it sort of makes sense to think about there being some sort of prior distribution which might apply to this individual. And we might want to incorporate external information outside the trial. For example, the clinician and the patient think a priori that one treatment might work slightly better than another, or that they don't expect the treatment effects to be too big or too small. You can incorporate that, and that helps you maybe to shorten the amount of time you need to actually do the analysis. The other thing is that if you use the Bayesian framework, you're allowed to make now probability statements about how well one treatment works compared to another. And so that might be a lot easier for somebody to understand in terms of what's my final decision going to be, rather than using a p-value. As we know, a lot of times p-values are misinterpreted, particularly by individuals who've never taken a class in statistics. And the other problem is that a lot of times we don't have a lot of data, and so standard frequentist methods are just not going to really have enough power. And so we may actually need to incorporate some of that extra information. The other thing, too, is that if you get a posterior distribution in a Bayesian framework and you have a probability, for example, my posterior probability is 83% that one treatment is effective. So in some sense, that doesn't reach our standard threshold of 95%. On the other hand, if I told you that there's 5-to-1 odds that one treatment works better than another, you're probably more likely to take the one that's on the 5 rather than the one that's on the 1. It's not like we're trying to worry about a type 1 error here and we're worried about things as we would in a regulatory situation. The other thing is that the Bayesian framework also makes it much easier to combine multiple N of 1 studies into a kind of one multi-level model. And I'll talk about that later, but it does allow you to now make inferences about one person using information from other people. So what kind of results are we presenting here? Well, as I said, you could do this all visually, so graphs are very useful. We'll oftentimes report probabilities or odds of comparing the two treatments. Again, it's not really hypothesis testing, it's more a decision-making strategy. And so we would give somebody the effect size, the uncertainty with that effect size, and some sort of probability connected to it. And we try to customize that in a way that people understand. This is one of the things that's sort of a research question right now, is what is the best way for people to understand this kind of information? So let me get to a couple of examples. So the fibromyalgia study that we did a few years ago, as I said, we compared two treatments. We published this in the I should put the reference here. It's I think the Journal of one of the rheumatology journals. And I worked with Debbie Zucker on this. What we used here is I'd done an earlier crossover trial in 19 patients. We had looked at amitriptyline and fluoxetine singly together and a placebo, and we'd found that the combination seemed to work best. And we would using the fibromyalgia impact questionnaire as our main outcome here. And so the N of 1 trial was meant to test the combination versus the amitriptyline. So in the original study, not all the patients responded. We were one of the things we were interested in is who would actually respond. So if we looked at improvement of 25%, the original study was a crossover where there were 4 treatments, so each patient received each treatment once. And so 5% of the patients improved on the placebo treatment period, 24% on the amitriptyline alone, 32 on the fluoxetine, 62 on the combo. So we were sort of interested also in saying, well, this treatment doesn't seem, even though the combo seems to work, it doesn't work for everybody. Can we do an N of 1 trial to figure out who it works for? And so we were hoping here to verify the earlier result across the population, but also to get some information about individual efficacy and to see how this would work both in a community setting and in an academic medical center setting. So we ended up using 1 referral practice and 7 community practices. One of the interesting things here was that when we originally designed the study, we had thought to reach out directly to rheumatologists, but we were having trouble recruiting people from the rheumatology practice. And we found out that one of the problems was a lot of the people that they see had already tried these drugs with their primary care physician. So we needed to actually change our approach a little bit more and actually go back to the primary care physicians as well as the rheumatologists. What we designed here was 6 intervention periods. So there were 3 crossovers of 6 weeks each with 2-week washout periods. So this was a pretty long trial. This one actually lasted 9 months. And we took 1 measurement at the end of every period. We randomized in blocks of 2, and our main outcome was the FIQ. So here we gave various information back to people. This was one of the things that we gave them a plot of where they were at baseline and where they were during the study, blinded in some sense to A and B, so they didn't know which was which. In the FIQ scale, higher is worse. So this is a picture where it's not really clear which one you did better on. And in fact, there doesn't seem to be a huge change from baseline. Another piece of information we gave people was probabilities. So for example, what's the probability, again, that B is more effective than A? Again, we can do this because we're in the Bayesian setting, or that A is more effective than the baseline, or that B is more effective than baseline. And we gave them 2 sets of probabilities, one using only their data and the other using the prior. And the prior we used was the prior from the original crossover study. So that gave us some estimate of the difference between the true treatments a priori. And as you can see, at least for this particular patient, who's not the one that I showed you the graph of, these probabilities are pretty high. So not only does each drug seem to work better than the baseline, but B seems to be a little bit better than A, and it doesn't really seem to matter whether you use the prior or not. So this would be a fairly clear decision. So at the end of this trial, 24% of the people chose the single drug, 64% chose the combo, 12% chose something else, and 88% of the people who completed the study were happy with it and said, this is a really good idea and I'd recommend it to somebody, which was nice. A second study I've been doing is the MINAP study, Melatonin in Youth. This was the study where we're looking at ADHD. It's a randomized, double-blind, placebo-controlled, multi-center trial in Canada and Australia of aggregated N of 1 trials compared to a parallel group RCT. So we're looking here not just at does melatonin work better, but does the N of 1 give us information that the standard study, which would just use 1 period, would not give us. And so we're looking at the effects of melatonin on sleep onset latency in children and adolescents. We're going to use 3-pair crossovers for 6 weeks. So they're on for a week and then off for a week in a randomized fashion. And there's going to be 300 people here, and we're going to stratify them by country and also by age. So that one is underway. I think the recruitment's kind of slow, so hopefully that one will actually get completed. The study I wanted to talk most about is the one that I've been working on for the last 4 years called Preempt. This is the one on chronic pain. We're actually at a stage now where all the patients have completed their treatments and we're getting to the analytic phase. So chronic pain is obviously a big problem in this country. It costs a lot of money. A lot of people have it. It's got a lot of consequences, and it's very hard to treat. People try all kinds of things for their chronic pain. And there's a lot of risks. Obviously, opiates are being abused these days because people get addicted to them. And this is one of the common reasons why people get addicted, is because they're in pain and they're taking these strong medications. So the idea here is to develop a mobile app to conduct N of 1 trials among adults with chronic musculoskeletal pain. And so this is a study where the RCT is actually comparing N of 1 versus standard care. And then within the N of 1 arm, people are doing an N of 1 trial where they can choose which treatments they want to do. So we're interested not in just comparing N of 1 to standard care, but we're also interested from the point of view of what are the N of 1 treatments they're comparing, and then also just in the methods in terms of how this works, because we're able to collect this information in a lot of people. In the main RCT, which is comparing N of 1 versus standard care, the outcomes are going to be things like, how well are you feeling 6 months after the study. So we want to see whether doing an N of 1 will help people sort of medium-term pain. And so we're going to look at things like quality of life, decision-making, satisfaction, trust, and adherence. So maybe if you do the N of 1, you're more likely to stick with your treatment plan. We're going to compare two interventions. As I said, people can choose which ones they want to do. They can choose whether it's a 1 or 2 week period that they're on the treatment. They can do 2 to 4 cycles. So these studies can last anywhere between 4 and 16 weeks, and we randomize them for every 2 weeks. And so they make all their choices. We give them a menu of outcomes that they report on, but they can choose which one is the most important to them. So here are some of the treatments that have been chosen by the people in the study. We have about 100 people randomized to each arm. And so people have chosen anything from no treatment at all to taking Tylenol to taking codeine and more intensive drugs, as well as complementary treatments like yoga, meditation, and so forth. The main outcome measures in the N of 1 arm that people report on every day are their daily pain, their daily sleep, their fatigue, their drowsiness, constipation, cognitive functions. And if they have neuropathic pain, they report on that as well. And adherence. This is kind of what it looks like. It's a little app on your phone. You go in and you can download it from the Google Store or the Apple Store, and then you answer your questions on there every day. You can look at little charts of what's happening. It's not particularly easy to see, but you can turn things on and off. It's interesting now that we're beginning to get some data in from people. Actually, this is one of the things they like the most, is that they're able to follow along from day to day how they're doing. So it's not even so much whether they did better on A or B that's important. It's more that they're sort of getting involved in their care. They're learning more about how they feel every day, and whether they, if their pain is cycling, may not have been something that they were aware of. So hopefully, I'm actually involved with some of these same people. WNYC, the public radio station in New York, has contacted us. They're interested in doing one of these studies for their listeners with thousands of people, where they might look at something like, we've been talking about different interventions, but one that's been kicked around is randomizing people to either use or not use blue light on their computer before you go to sleep. And does that have an effect on how well you sleep? But there's lots of other things that we could do that people might be interested in. And the idea is people are collecting all this information anyhow, so how can we make it a little bit more scientific? Right, so again, another advantage here is that there's barriers to participation in studies, and hopefully all of this kind of interaction with people will help to control some of these challenges, like, we have missing data. Well, hopefully by people participating, they might be more likely to respond every day because they're interested. Or the outcomes aren't personally relevant, people drop out. Well, you've chosen your own outcomes here. So, the results aren't, I don't know what these results mean. Well, you've customized these results to your own setting. So hopefully a lot of these barriers will be overcome by this type of study. I don't want to say a lot about the analytic models. In our study, we have continuous outcomes like pain, and we have categorical outcomes like sleep, which are scored on a Likert scale. So we use linear models and ordinal categorical models and that sort of thing. And we're adjusting for things like the treatment effect, the correlation, and time trends. So we have a variety of models, which I won't share you, and I'm happy to talk about. And I've actually got a PhD student working on this now. We're trying to develop some software to analyze these. So what does the final display look like? Well, in our trial, we've used a few different displays. One is just sort of showing you a time series graph of what your data look like. Blue, you're on one treatment. Red, you're on another treatment. You can look at that by time or by treatment. You can look at averages. You can look at bar graphs where you look at the 5 or 6 different outcomes and compare them. Another way we're looking at things. So the top graph is more of kind of your usual kind of point estimate and confidence bar. The 6 rows here are the 6 outcomes from pain, intensity, fatigue, drowsiness, sleep, and so forth. The red is the area where treatment A is better. The blue is the area where treatment B is better. Dark color means you're clinically significantly better. Light color means you're in the clinically insignificant region. The circle is on the posterior median, and then you have a 95% posterior interval there. So for example, for pain intensity, you can see that there's a small effect, which is all in the clinically insignificant region with about 95% probability. Whereas for drowsiness, it looks like treatment A actually is probably working better. And I noticed that the screen has a line on it, which you should probably ignore. Or another way of looking at it down in the bottom is these are posterior probabilities. So what's the probability that you're in the dark red region, the dark blue region, or the light red or light blue regions? And so, for example, if you just look at that overall picture, it seems more red than blue. We're in Maryland, which is unusual. But in this case, you might say, well, the red treatment seems to be working better on most of these outcomes. However, if you were most interested in constipation, then you'd focus on the bottom one and say, well, that's 50-50, and so I really don't know. So we're kind of thinking about different ways of displaying the information here. Here's another way to look at it. The likelihood one treatment's better than another. This is the same picture as on the previous slide at the bottom, but now we've just broken it out into more categories. So now you see we have different shades of red and blue. I actually sort of wanted to do this as a heat map, but the clinicians thought that was a little overwhelming. So we compromised on 8 categories. But the white here would be a region where you're between 0 and 5%. It doesn't really matter. So now let me just show you a few plots before I end here. So this is, again, work I'm doing with my PhD student, Kelsey Wong. So we're fitting different models to these data. So these are 4 different individuals in this study. The black is on one treatment. The red is on another treatment. The dots are the data. So if you look at the upper left, you can see that this individual for the first 14 days was on one treatment, and then they switched over to another treatment. And you can see that it's kind of all over the map. So one question might be, well, what's the difference here between the black and the red versus the time trend? And so we're actually using splines here to fit the time trend. And you can see that they're very kind of idiosyncratic here. And so it's kind of hard to figure out what's going on. Maybe a more interesting one is the bottom left. So here's one where if you actually just did a standard sort of t-test kind of comparison, comparing means, it would appear that the red treatment is better than the black. On the other hand, if you look at the time trend, you can see that there's a U shape, which might indicate that this patient is sort of cycling from high pain to low pain back to high pain. And so when we do the adjusted analysis here, there's no treatment effect at all because it's basically explained by the time trend. So this is somewhat problematic for a single individual. Which do you believe? Are they cycling or are they really getting better? Well, if you look at this a little more closely, you'd expect that if the treatment is working, their pain should be getting reduced. Well, that seems to be the case in the first period there. The red curve is moving down. But then the black curve continues to move down, and then it starts to move up again. So you say, all right, well, maybe the black isn't working because their pain is continuing to increase. But then if you look at the final period, the red is increasing as well. So, maybe the time trend is really what's going on there. So that's what we're kind of struggling with right now. We're hoping that by combining across all these individuals, we might find trends that we can sort of borrow strength across and get a better idea about what the overall treatment effects are here. So you can see right away there's an application to meta-analysis. So here's another way of thinking about this. The red dot here is the overall effect, which is pretty close to zero. And the black curves are density plots of the posterior probability for individuals. So you can see that they're fairly wide. We have a lot of uncertainty about what the true effect is here. And in some cases, it seems a little negative. In some cases, it seems a little positive. But if you actually count the probability in the clinically significant versus insignificant regions, it's actually fairly small. And if you remember, the clinically significant was plus or minus 20. So, most of the probability here is really not in that range at all. Here's another way we're looking at the data. Again, this is thinking about these different ranges of significance and looking at this across subjects. So this is sort of a different way of displaying that plot that I showed you a couple of slides ago. Now, this is done on an individual basis. Obviously, if we start combining across individuals with some kind of a hierarchical model, then we can borrow strength and adjust these probabilities for the averages. So I'm not going to usually have enough time when I do one of these studies. If people are automatically doing these, and I've got a few of these coming in every day, I can't sit there and analyze these data. So we need to automate this. So this is what we've done at the back end of the app. We have an R program that does these calculations with different types of models and spits back out the answers, and people can then customize them to how they want to look. So when you're automating these now, we have to have automatic rules for choosing which model is best. And so that's, again, something that we're working on right now. If there's missing data, we have to be able to account for that. And so this is something that it's complicated because you not only have to automate it, you have to choose between models, but then you have to present the results in a way that people who are actually making the decision, who are not statisticians and may not even know anything about statistics, can sort of understand. So this is sort of an interesting idea. And so we're looking at a variety of different ways of checking the statistical analyses. Again, I'm not going to get into details on that. And then finally, this is just a schematic for how you might combine data. So you've got data on 7 individuals here who were seen by 4 different doctors who work in 2 different centers. And so you now have this multi-level kind of hierarchical structure. And so you can think about making inferences at any one of these levels. What's the average patient effect? What's the individual patient effect? What's the average doctor effect? What's the average center effect? And how do those effects inform what's going on? So again, the advantage of doing it this way is you can not only make inferences about individuals, but you can make inferences about the population. So you can think about this as a kind of repeated measures design or a kind of meta-analysis design where the unit of analysis is the patient and inferences are being made to that unit, but also to other units. And so then you have to think about what kind of covariance structures you're using and what kind of model you're using, where each study has a univariate outcome. So there's a single variance, but you have unequal weights across the studies according to basically how much information you have on each person. And then you can combine that all into a multi-level model where we're basically weighting the population effects with the individual effects in a certain way. And of course, then that depends on what the model is that you're using. So again, I'm not going to get into the details here, but that's the basic idea, is that you might get more information from learning about other people. If I'm a doctor, my patient is doing pretty well on this drug, but it's not obvious, but every other patient I've treated has done really well on that drug, then I'm probably more likely to believe it will eventually work for the one that I'm looking at, which is, I think, fairly similar to the way that we typically think of these things in general. And so we've done a little bit of work on meta-analyzing some of the data we have from the PREEMPT study. So the red here are the individual analyses, and the black are the meta-analyses you can see in general, because the overall effect is fairly close to zero, that the overall, the meta-analysis is pulling the estimates back towards zero. So for example, if you look at patient, let's see, it's 8 here, I believe, is the biggest difference. If you can see patient 8, I think that's the individual that I showed you before where it wasn't clear if it was a time trend or a difference. So if you just look at their individual data, it looks like they're doing well, but when you pull them back to the mean with the time trend, you get rid of that effect. And then we could generalize this to network meta-analysis, which will make Tianjing happy. In this trial, we have not just 2 treatments. People can choose what they want. These are all the treatments they've chosen. It's a real mess of a network meta-analysis because basically, if you look at everybody's treatment, they're all unique. So we have to group them in some way. The strongest comparison is between acetaminophen and NSAID, but there's lots and lots of other combinations. And so with 100 people here, this is sort of a little network. And we're sort of struggling with not just how to kind of model this, but also how to even construct the network. So there's a lot of social benefits to this. We can engage patients in their own care. We can enhance scientific literacy in the population. It's a nice example of personalized medicine. Can improve clinical practice because you can get more doctors involved in research, enhancing communication between the patient and the physician. You can generate randomized data, which might help us in the long run understand what works and what doesn't work. And we can combine across individuals and learn more about how these things operate. And so I'm going to close there and happy to take any questions that people might have.
With the multiple crossovers within a patient, do you have any kind of problems with people saying, well, I've tried both of these drugs now and this one worked way better, so I'm just going to stay on this one? Is that
right? So that's one of the problems with the dropout that I was mentioning. So let's say even if you're blinded, well, certainly if you're not blinded, yeah, I mean, I did much better on yoga the week I did on yoga than I did the week where I took the pill. So I'm going to stick with the yoga. So that may be okay for that individual. On the other hand, I think what a lot of people don't understand is variability. And so they might not understand that the reason they did better that week on the yoga was because they didn't have a big thing in their office, a big project they were working on, and so they were much more relaxed in general, right? So, so that's why I'm saying I think there's a whole scientific literacy thing here that we may be able to help people out on, is stick with it another week and see if it continues that way.
When you were using the mobile app, you said it was in the context of a clinical trials comparing the standard of care to N1 trials. Mm-hmm. Did the standard of care use the mobile app?
No, so I wasn't clear on that. So the N of 1 used the mobile app. The standard of care is just usual care. So basically, people get randomized to one of those 2 arms. If they do usual care, they're just working with their physician as usual. And after 3, 6, and 12 months, we query them on how they're doing with their pain. Whereas with the mobile app, they're doing these interventions for a certain amount of time. They stop it, and then we query them later. And so then the comparison is, the people who had the mobile app, are they different from the people who just did standard of care?
Well, just one short follow-up. But you said that what people really liked was the mobile app. Or you indicated
the people in the N of 1 arm really liked, what they liked about the mobile app was not even so much that it told them which treatment to take, but just the fact that they could follow what they were doing. Now, the people in the other arm didn't have that, so we're not surveying them. But
well, sorry, I'm just wondering, what do you interpret from that, the overall clinical trial? Because this is where the phase we're at. We're going to be analyzing now to see whether the people in the N of 1 arm 6 months afterwards, whether they're doing better than the people in the other arm. It may very well be that having now followed their own outcomes closely on a daily basis, they're going to continue to do that. And so they're going to be much more aware of what their triggers are. And so 6 months down the road, they're actually doing much better than the people in the standard of care. But we don't know that yet until we look at the data. It just seems to be conflating the app with the N of 1.
Yeah, well, the app is part of the N of 1. So yeah, we can't necessarily pull apart the app from the N of 1. I mean, the N of 1 is with the app. So it's really it's a combined treatment there.
I guess I have question, which is, so basically the effect you're going to observe is a combination of all these treatments going on, as well as the design effect, that's the fact it's in a one trial, as well as the mobile. So there are three things going together on that one arm compared to the standard of care. And
Right.
then you necessarily tease apart, is that the treatment they're doing really effective, or it's the design that they're being a part of the in the one trial, or it's the mobile app that really made the difference?
Yeah, so I guess at the sort of the most crude level, we're just saying, if we allow you to do an N of 1 trial, we give you a mobile app to carry that out, and we allow you to choose what treatments and what outcomes you want to look at, will you do better down the road than just doing usual care? So if we say yes, then we have to tease apart, okay, is it the fact that you could carry out your own treatments? Is it that you had this phone that allowed you to see how you're doing, or what is it? I guess to some extent, maybe when we started, we weren't thinking that following their own course from day to day would be that important. So that's kind of one of the things we've learned about from some of the qualitative studies we're doing on follow-up, that people really like that aspect of it.
For some of these conditions, have you thought about having a longer period at baseline for control, where you just check for variability in temporal trends, and then you compare later on in the treatment period?
Right. So that's a great point. And actually that would help a lot in the design phase, because different individuals will have different types of variability and different types of potential cycling. And so some individuals you may not need to study as long as others, right? If somebody's fairly stable, then it's going to be pretty clear whether the treatment has an effect or not. If somebody's highly variable in how they're doing from day to day, then you may need to study them a lot longer. So I think that's, again, those are good issues. I mean, this is a wonderful area for research, because really there's tons and tons of questions, both statistically, design, qualitatively, all kinds of stuff.
So I'm trying to understand, when you do it as just an N of 1, it's to personalize treatment for the individual. I can't imagine you would publish that. Look, Ms. Brown did better on this treatment. But when you do multiple N of 1s, what is the benefit compared to usual randomization? Is it because of the multiple crossovers? That's the benefit, or?
So there's two benefits. Yeah, one is that there's multiple crossovers, but the other benefit is you're actually able to make an inference about the individual. So if you think about it, if I randomize 100 people, and so I can now make an inference about the average effect, but I can't necessarily make an inference about the individual's effect. If I look at 100 people 50 times, then I can make an inference not only about the population with more power, because now I've got 5,000 measurements and not 100 measurements, but also because I can make inferences about the individual now. Okay.
So how would you evaluate the quality of N of 1 trials?
The quality. I guess one would just be, did you get all the data? So missing data would be one aspect. Another one might be, so you might say, well, how well did they stick to their treatment regimen? I think that would be pretty much similar to any clinical trial. I mean, you might have like a pill box or something. But also because they're filling in these things on a daily basis, you might be able to ask them questions. One of the things I didn't mention here, which we had in the app, was we had a diary. So they could fill in every day a textual comment. And I have a student looking at this because we're sort of interested. Can that tell us a little bit more about why people did what they did? And we found that the people who were in more pain seemed to fill in the diary more often. What I was hoping was that we might have answers to questions like, well, why did this person's pain drop or rise? Maybe they said in their diary, I had the flu today, or I got in a car crash today, or my kid was sick, or my kid, I don't know, something, I had a big fight in the office or something, it might indicate kind of what was going on. So, that's another thing that is, in terms of quality of data, it's sort of a level you can get at that it may be harder to get at in a randomized trial. But the other aspect is that typically in a trial, you have this whole infrastructure for collecting data, monitoring it, and all that kind of thing. And so when you're doing the N of 1, particularly in these small community settings, you may not have that. So this is why we're thinking that the mobile app may allow more people to do these studies who wouldn't otherwise be able to do them, because it will do the randomization for them automatically. It'll do the data collection and that sort of thing.
Last quick question.
Well, there's a question up here.
Thank you. So I was thinking for the application of this research, because it can make inference about individuals, so we can identify those respondent as compared to the non-respondent of certain drugs. So that's we can take a further step to apply this research result to do the say like pharmacogenetics research.
Right. Yeah. So again, going back to the question of kind of what do we gain from this, we have an overall effect, but we also kind of know who responds and who doesn't respond. And we could then explore that further. So you might, for example, find that the responders had certain characteristics that the non-responders didn't. Yeah.
And the problem of this clinical crossover is that you cannot tell the long-term adverse event of certain drugs.
Well, yeah. I mean, so there's always going to be some drawbacks. You're right. Yeah. I mean, it's unless you did the study for a long time, right? So if it was something which took a long time to manifest in terms of the side effects, yeah, you wouldn't be able to figure that out here.
So Dr. Schmid will
Can I
be
follow
here.
up that? Just a follow up. So you said there's certain characteristics that work.
Mhm.
Can you take the characteristic from one individual and combine it from another and from another to create another individual, because this is individualized?
Right.
Okay.
Right. So in addition to getting sort of a population effect and individual effect, you can also get a subgroup effect, obviously, too.
And you combine them.
Right. So in a standard trial, you might be able to say, for example, younger women do better than older women, right? Here you could say, you could do the same thing, but you might even be able to get sort of more specific because you now have individual characteristics on each person and you have multiple information on each person. So because you have a better estimate of each person's effect, you may now be able to get better estimates of subgroup effects as well. So this is, again, something that nobody's really thought of because this is all kind of new. So